Now we shall continue with the way to train patients with eccentric weaving training. Okay, first of all, we need to do a few assessments before we can start training patients. The first assessment that we have to do is visual acuity taking and also contrast sensitivity of the patient, together with visual field test, which is going to be using a Jerome screen test. The The reason why we use Jerome screen test is for us to identify the location of the of the central scotoma that the patient is having, and also to determine the size of the scotoma. Why we need to know the size and also location of the central scotoma is for us to determine whether we can train or suggest the patient with central eccentric weaving training or not. Because if, let's say, the central scotoma that the patient is having is bigger than 20 degrees, the size of the scotoma, we're not able to train the patient effectively with eccentric weaving training. So that is the reason why we need to do the Jerome screen test. And also with the identification of the location of the central scotoma, it eases us to determine the PRL or predict the PRL, the preferred retinal loci, or the the peripheral macular part, which is still intact for us to train the patient with eccentric weaving training. So that is the reason why we have to do a visual field test using Jerome screen test. One is to determine the size of the scotoma. Number two is the determine the location of the central scotoma. Once that is already determined, then we need to establish the need of the patient. So the need of the patient may vary for distance and near. Certain patient, they doesn't want to do any near activity. They're not interested in that. So when we train, right, there is a separate when we train this eccentric viewing, right? Okay, first of all, you have to know that when we train patient with eccentric viewing training, okay, most of the patient would have actually habitually adapted to one adapted to eccentric viewing already. Okay, why? Because most of the time our vision will be, looking. We will be using our vision most of the time for distance. Okay, so when they can't see things at distance while moving, while walking. Okay, when they can't see things at distance, they will try to actually move their eyes and see at any position they could actually make it better or not. So from there, if let's say they know that if let's say they move their eyes slightly downwards, they can see things clearer. So they would have actually habitually adapted to that item. Okay, so for that patient, we don't need to train them with eccentric viewing for distance. Okay, instead, then what we do for this patient is we train them only for reading purpose or the near work need. We try to actually help them with that. Okay, well, and there will be another group of patient who is actually, not using eccentric viewing training. They don't know what, that means also. So for that patient, you have to train them with distance first and then discuss with them they do any new work or not. If they do any new work, then we train distance first, then we train the near. Okay, if let's say the patient does not have any need for near, then we just only train them for distance. Okay. So once we already, know what the patient needs, then we establish the need of the patient. For example, if let's say the patient needs both the exercise, distance and near, okay, then we tell the patient that, okay, we will start with the distance first. And then once the distance is already adapted to the eccentric viewing and you habitually can do that without any problem, then we will actually do the near eccentric viewing training. So it goes step by step. First start with distance, then the reading or the near task. So that is how you establish the need of the patient. Okay. So once you're done with that, then we locate the PRL. Okay, we try to locate the PRL using screening cut number 1. And if you look at the picture over here, right? If you look at the picture, this is screening cut number 1, the one with smileys. And this is screening cut number 2, the girl's face. Okay, both of this is screening cut number 2. So in screening cut number 1, okay, when we use this, we actually, doing this to locate the PRL, the preferred retinal loci of the patient. So basically, when you ask them to look at the center, right, there will be central scotoma blocking the patient. That is the reason why the smiley has a line connecting to each other. So we ask the patient to actually look at the center and then try to, obviously we cannot fixate at the center because the vision is blurred or with central scotoma. So what we do is we ask them to imagine the intersection point of these two lines and only focus at the imaginary intersection line throughout this procedure. So once they already start fixating, then we ask them to, okay, and also the card has to be held about 30 to 50 centimeter, any distance at that. Okay. So at 30 to 50 centimeter, and then you ask the patient to keep looking, fixating at the intersection point. And then while they're fixating to the intersection point, they have to let you know which smiley appears to be the clearest. Okay, once if let's say the patient say the right is clearer, okay, or sorry, the right is the clearest, then we shift to the next chart, which is the horizontal version. If let's say the patient say that, oh, the top is the clearest, okay, when patient say top is the clearest, then we have to move the to the next step using the vertical one. Okay, if let's say it's a top or bottom is clearest, then we use the vertical one. If let's say right or left, then we use the next chart to be the horizontal one. So once we already locate and we know that the visual field size is less than 20 degrees, then we proceed with this. Okay. The next, once we know, like for example, I give you one example and continue with that. Okay, if let's say patient say the right smiley is the clearest. Okay, then what you do is you take a screening cut number 2, give it to the patient. Obviously, when you give it to the patient would see something like this. The details of the central face of the kid is not clearest. Then what you do is when the patient say right smiley is the clearest, you move to the opposite side. The eye has to move with the opposite sides to make the face receive more information. Obviously, the clarity is not going to be good while you're looking straight. Okay, so it is going to be giving additional information to let you know that at least what is the name of the patient or the name of, sorry. So basically, we ask them to look at the site and try to actually get additional information related to the picture that is being shown. So that's the idea of it. It's not going to give you the clarity that we have with no central scotoma. The initial days without central scotoma, it's not going to give the same thing. It's only going to give you some information. Okay. So before we continue with screening cut number 2, I'll just like to explain, right, the centric viewing training. Okay, you should have better understanding that when you are using your central vision, the vision is going to be giving you the clearest HD vision. Okay, but when you are using eccentric viewing, right, it's going to give you extra information. Okay, how do I actually explain this? Is you take a cross, okay, draw up on a paper a cross, then put it on the wall, and then take a a small toy or anything, put it just a few centimeters away from the cross, and then do yourself, okay, keep looking at the cross. The cross will be clear for you, okay, because you're normal. But if let's say patient is having central scotoma, when you're looking at the skull, then it's going to be difficult for them. Then while looking at the while looking at the cross, try to make the in try to make the image of the toy to be clear, okay, while fixating at this. Okay, although you're going to actually make something like, you know, what is a toy, what kind of toy is that, but the details is not going to be as clear as it was before the patient gets the central scotoma. It's only going to give you some additional information like this, right? If let's say the patient is having scotoma like this, they wouldn't know whether it's a girl or boy. Okay, but when they move, when, according to this case, when the patient moves to here, okay, move the eye to this side, this image of the kid will be slightly with more information. It's not going to give you a clarity, but it's going to give you some uh, uh, information to know about the object that they are looking at. Okay, so that's the idea. So once the screening cut number one is actually, performed on the patient, the next one is we use this um, screening cut number two to teach the direction and distance of prefixation. Okay, so basically just ask patient to look at the center, and obviously the image of the kid is not going to be clear. Okay, then what you ask them is move. Okay, example that I gave just now is right side is clearest. Now you ask patient to move their eyes to the opposite direction, to the left side. Okay, until the image appearing the clearest. Okay, some patient might need to move about this much only. Some patient need to move this much. Some patient need to move this much. So it's very depending. Okay, so once they already, by for example, right side is the clearest, you ask the patient to move their eyes to the opposite side. If let's say at this line patient already able to, make the maximum, take maximum information, then ask them to stop there and repeat a few times so that the patient does not need this charts to actually, look at every time, you know, it's not like that. Okay. So basically once, no. Okay, I try to rephrase it. Okay. So once they already, already trained with this, right? They cannot be using this chart forever, okay, to determine the refixation, how much they have to move their eyes to see things very clear, see things clearly, okay, at the center using the center vision, okay. So if let's say they move up to here, then here will be, slightly clearer, for the patient at least, able to know, a certain things or features in here. So what we do is you can just print out this, okay, give it to the patient, and then the patient will bring back and try to actually, do this daily, at least, 2 to 3 minutes maximum, okay, morning once, and then before go to bed once, okay, to determine whether the change of fixation help them. No. Basically, this training is to actually, apply practically what they learn. Sorry, come back again. Sorry, I got confused with the 7 point. Okay, so they bring back this home and then they practice daily 2 to 3 minutes morning and before they go to bed. Okay, what they do is they try to move and make this face clear. Okay, every day. Okay, every day. And then, at one point of time, because they're practicing this daily, right? Okay, at one point of time, they don't need to look at the chart. They know that they have to move this much only to make the central vision clear. Okay, so what you have to do is once they're already done with this, ask them to come back. Okay, and then we do the next thing. We ask them to do daily activities using the eccentric viewing, and then come back after 2 weeks or 4 weeks. Come back and report to us. Okay, report to us whether it is good or bad, or it is not comfortable. Okay, or something is not right. Okay, once they give the feedback, okay, if let's say something is not right, we try to actually redo this and see. If let's say everything is going good, then we just ask them to apply this, whatever that they learn, within the screen number two, right? Okay, next thing is you ask them to, go back home and try do daily activities. Okay, for them to gain the confidence of doing this eccentric viewing training and see how it is related to the real activities comparing to the chart that is given initially. Okay, so once you're already done with that, then teach application class, which is experiences. Now they go, they come back. Okay, once they're already very familiar, then now if let's say they say that now I know that I have to move this much to make things clear at the center, that means it's good already for the patient. Okay, once you already receive that feedback, then you can continue with the teaching the reading skills for the kid or kid or even elderly also can. Okay, teach the reading skills. So first, we modify this chart. We try with the first one is to be the letters. Okay, do the same thing. This one no need to do again. So just create a table, put a word, a letter, and then what we do is we ask them to read. Okay, by moving the eyes to the opposite direction, and then ask them to read the letters that is being shown to then increase the complexity in the paragraph and see how the patient is actually coping with it. If everything is good, then the patient is good to go for the eccentric viewing. Okay, so when it comes to this eccentric viewing, right? Okay, one the disadvantage of this eccentric viewing is the cosmetically the patient won't look good because if let's say they are talking to someone, okay, the eyes will not be having eye contact. Patient will be turning the eyes to the side. Okay, so we have to discuss with the patient whether this is helpful or not. Okay, whether they're going to actually practice this, and also they have to actually be uh, if let's say everything is like okay, coming back, if let's say everything is okay, patient is fine with this, although it's not going to look great because while they're talking to someone, they will be looking in somewhere. So people will know that this patient is actually having a vision problem. Okay, so that need to be that thinking shouldn't be there, because cosmetically it doesn't look good, but I don't, because I don't want to, how do I say, cosmetically doesn't look good, but it is benefiting me. So to that should be convinced to the patient. Okay, which one is more important? Is it the cosmetic purpose or is it, the vision and work? If let's say the patient is, uh, you know, very concerned about the cosmetic reason, then you can avoid, convincing them to do this. If let's say some other reason, it's tough, it's difficult and all that, then we can actually, troubleshoot that. Okay. So that is what you have to remember is cosmetically it won't look good because they will be having a weird item. Okay, another thing that you have to remember, okay, this chart you hold at 30 to 50 centimeters. This chart also you hold it at 30 to 50 centimeter. Okay, that one that you have to remember. And when they do this, okay, practice a few times, then they will get it. Okay, but limited time only. It cannot be, half an hour, 1 hour of practice at home. No, it's going to be very tiring. Until they get used to it, then they can do it for all the time. But beginner, they have to be very, easy. How do I say? Yeah? Okay, forget about it. It's okay. I got lost. Okay, so this is eccentric viewing training. So this is how we train patient with eccentric viewing. So we use screening card number 1 and we use screening card number 2. Okay, so all screening card number 1 and screening card number 2, and I already taught you on how to use this screening card number 1 and screening card number 2. Okay, and what are the factors that contribute to whether factors that contribute to with a success of eccentric viewing training. All that need to be clarified earlier. So, before we approach patient, we need to have like an idea whether this patient will actually, be able to follow our instruction or not. Patients who are having memory problems and all that, right? It's quite difficult for them. But once the eccentric viewing is the gaze is actually established on this patient, they can do it. But there will be a struggle for certain patients like kids or elderly patients to follow this instruction, because it is like it needs a lot of time. Another one is high motivation is much needed, because it's going to be very tiring. As I mentioned, it's only 2 minutes of exercise, not more than that. Okay, so that will also affect the the success of the eccentric viewing training. Okay, so we will continue on the peripheral visual field defect in another lecture video. Thank you.